To begin this webinar, let's us proceed the inaugural event, sing the national anthem of Indonesia Raya. Ladies and gentlemen, please rise. Thank you, ladies and gentlemen. Next, we will listen to the opening speech of Head of Neurology Program, Diponegoro University, Dr. Arinta Puspitawati, Specialist of Neurology Consultant. Please welcome Dr. Arinta.
Good afternoon, my respected Professor Hrishikesh Kumar, Dr. Santoso, Dr. Elta, Dr. Banon, and all Zoom participants. This afternoon, we are very happy to have the opportunity to listen and have a discussion about movement disorder with Professor Hrishikesh from Institute of Neuroscience, India. I, Dr. Arinta, as the head of the Neurology Program, Faculty of Medicine, Diponegoro University, would like to thank you, Professor. It is an honor for us that you are willing to share your knowledge, your experience, especially with our student in Department of Neurology, Faculty of Medicine, Diponegoro University. Hopefully, this afternoon's event can run smoothly without any problems. That's all I can say. Thank you. And for all the students, please use this opportunity well and enjoy the discussion. Good afternoon. Thank you.
Thank you, Dr. Arinta, for the speech. Next, we will have a virtual photo session together. Please turn on your Zoom camera. Ladies and gentlemen, please turn on your Zoom camera. Okay. Smile, everyone. 3, 2, 1. Once again. 3, 2, 1. Okay, let us now proceed to the presentation of the material that will be led by our moderator, Dr. Elta. She is the neurology lecturer in neurology program at Faculty of Medicine Undip, and she graduated her medical school also in Undip in 2004, and then continue her neurology specialist and biomedicine study, graduated in 2014. Right now, she still continues her study in doctoral program biomedicine in Indonesia University. And she is now working as a doctor of National Diponegoro Hospital Semarang, Pelita Anugrah Hospital, and Siloam Hospital. Please welcome our moderator, Dr. Elta Diah Pasmanasari.
Okay, thank you, Dr. Siwi, and thank you, Dr. Arinta, for opening this scientific forum. Thank you, Dr. Banon, as the head of the Movement Disorder Society in Indonesia, to join us, and thank you for Dr. Santoso for joining us too. We will begin our scientific section soon, and I will take in charge as the moderator. And once again, I would like to thank you to Professor Kumar for the willingness to share the knowledge with us about the basic of movement disorder approach with the among patient. Okay, before we begin the scientific section, allow me to read the CV of Professor Dr. Hrishikesh Kumar. Okay, Professor Dr. Hrishikesh Kumar is the head of Department of Neurology in charge of Parkinson's disease and movement disorder program director of the RGCM Research Center in India, and he is the vice chairman of the Institute of Neuroscience in Kolkata too, and he is the secretary of Movement Disorder Society in India from 2021 to 2023, and he was a treasurer in Movement Disorder Society in India from 2019 to 2021, and a member of Education Committee of Movement Disorder Society, and the chief editor of the journal Movement Disorder in Clinical Practice in India edition, in Indian edition, and the editor of the Journal of Headache in Indian edition, and the founder president of the Parkinson's Disease Patient Welfare Society of the Kolkata. Okay, before we begin the scientific section, I would like to inform from the participant or the audience, if you have any questions, you can just write on the chat column, or maybe you can just ask directly at the discussion section after the lecture. For Professor Kumar, have you ready to
Yes, I'm ready.
your
Thank you very much.
lecture? Okay, please begin your lecture, and time in screen is yours.
So thank you. I'll share my screen now.
Yes, you can share your screen.
Yeah. For that, the host has to stop sharing, then I can share, I think. All right. So give me 1 minute. All right, this is great to be here, I can tell you. It's amazing. I am very happy to be with all of you. And thank you, Dr. Arinta Puspita, for a wonderful introduction. And thank you, Elta Dare, for a great start of the program. And Dr. Santosho is my friend and student, and he has started this connection. So thank you, Santosho. What I'll do today, that we'll speak about movement disorders, very basic clinical approach, so that any student who is in the early phase of career, they can also understand a bit of it. So it's not that I'm going to deep genetic condition. I'll go very basic. Suppose a patient comes to me, how to start with that. Before I move on, my voice is clear, right? My voice is clear?
Yes, it is very clear, Prof.
All right, thank you much. Thank you. So the relation between India and Indonesia, you can see through these photographs. We have been very close culturally, geographically, because when you see the boundary, some of the Andaman and Nicobar Island is very close to Indonesia, which is part of India. So I'm very glad to be with you at this point in time. And we all know that you do better than us when it comes to Ramayana and when it comes to a dance related to Ramayana. And Santosh has been wonderful gentleman, and he has learned a lot. He has taught a lot, because when it happens that we have a two-way connection. So he talks about his country, and he's a wonderful gentleman, and you can see that he's giving Botox here, botulinum toxin injection here, and he has learned quite a bit of things. So he'll be a great asset for your institute in coming days. He already is, but he will be further great asset. So let's start about movement disorders. Why this interests me, and maybe a lot of people, that this is the last citadel of good old clinical neurology. When it comes to stroke, MRI, and a lot of intervention has come up. When it comes to epilepsy, a lot of modern thing has come up. But movement disorder, still your clinical eye is very important. Without clinical sense, it's very difficult to go the first step also. Suppose you misdiagnose tremor as myoclonus, you're gone at that time only. Right? So it's very important to have some clinical approach in the movement disorders. So now I'll be in student mode again. Means I'll like to talk to, say, early student. A lot of you might be knowing it, but when a patient comes to me with movement disorders, the first thing to decide that he has been sent to me for movement disorders, but whether the patient has less kinesis, means slow movement, or more kinesis, means extra movement. So that is bradykinetic or hyperkinetic. So that's the first step to decide, and it's very easy to decide. Once you see the patient, you will know about that. But we have to keep in mind that some patients may have mixture of both. For example, a drug-induced Parkinsonism patient might have dyskinesia. Parkinson's patient, which is slow, might have tremor. So there can be a mixture. But first step is to see what is the prominent movement, low or high, right? So I'll have some videos, and I'll start with this. You can see this gentleman is very slow. His whole body is like very stiff, he's rigid. His Parkinson is, as you all know, but so this is less kinesis. On the other hand, this gentleman, his body is moving excessively. So this is hyperkinesis. The patient has dystonia. We'll come to this term in due course of time, but one has slow kinesis, one is hyperkinesis. And that's the way to start as the first slide. So when you talk about the coins of movement disorders or language of movement disorders, slow kinesis is very limited, only bradykinesia, rigidity. But hyperkinesis, that is hyperkinetic disorder, it has a lot of various terms. So if you are aware of that, wonderful. If you're not aware, I like to be aware of what is tremor, what is dystonia, what is myoclonus, and we should not confuse between them. And I'm not in favor of big definitions, because each thing has definition. I'm in favor of learning the keyword. What are the keywords? Moving on. So tremor is rhythmic. So rhythmic is the keyword. Rhythmic involuntary oscillations, RIO. So if the patient has a rhythmic movement, yes, that might be tremor. Involuntary, of course, and oscillations means going around an axis, to fro. So that is tremor. This is not tremor. This is actually posturing. So, and this is dancing movement. This is not tremor. But look at this. The patient has, you can see the left hand has rhythm. Some rhythm is there. Oscillations are happening. So this rhythmic involuntary oscillations is tremor. And this patient has rest tremor of hand, asymmetrical, one side more than the other side. And this patient rest tremor of the foot. And when you have rest tremor, first thing we think of Parkinson's disease. Action tremor, we think of something else. We'll come to that slowly. So this is tremor for you. Moving on, dystonia. Dystonia is not rhythmic. What happens? There's some contraction of the muscles, and contraction in a way that agonist and antagonists both contract. It's not like spasticity where only one part contract. Agonist, antagonist both contract. Because of that, there's bizarre posturing, abnormal posturing of the body part. Like this patient, he has truncal dystonia. This patient neck is moved towards left side. She has cervical dystonia, torticollis, and this patient has jaw dystonia. So mouth is open all the time. He is not able to close properly. He is not able to eat properly. Mouth is and he is not able to speak properly. So what he is saying, because of mouth opening, he is not able to do anything. So tremor was rhythmic involuntary oscillations. For dystonia, the keyword is abnormal posturing. There is some posture abnormal of the body part because of co-contraction of agonist and antagonist. So that's dystonia for you. Okay. So moving on, chorea. Chorea is funny movement. Sometimes chorea is so mild you may not see properly. You have to be very careful regarding chorea, because you might think that patient or the person is nervous. That's why he's fidgety a bit. That's why he's moving a bit. But chorea is slow movement, but flowing from one part to other part. It's like dancing movement. And sometimes in chorea, what happens during movement, they try to do something, and you feel that the patient is doing purposefully, but in fact, what they have done, they have incorporated the chorea into the movement, what we call a semi-purposeful movement. So let's see chorea first of all. This is a patient of Huntington disease. You can see that some little movement happening everywhere. Suddenly the hand went up and she adjusted the cloth, which was semi-purposeful movement. And this is not rhythmic, right? It's flowing movement from one part to other part. There is no posturing because movement is happening all the time, like piano movement all the time. So that's chorea. Keyword for chorea is flowing dance-like movement. Moving on, myoclonus. Myoclonus sometimes may look like tremor, but keyword is jerky movement. This is myoclonus where you have to and fro movement, but jerk, sudden jerk, that is myoclonus. Like this is patient of DYT11, a genetic condition, myoclonus dystonia syndrome. You can see that she has jerky movements, as if something is shocking her, right? So the word is shock-like contraction, that's myoclonus. Okay. And this patient has ataxia telangiectasia, but she also has myoclonus. You can see the head is jerky, whole body is jerky movements. So that's myoclonus for you. And finally, one confusing is a word is tics. Tics look like jerky, look like myoclonus, but tics is generally in the faciocranial part, and patient can suppress it for a while. If you ask that, please suppress it for a few seconds, they can do that. They cannot do that in case of myoclonus. So this tics. You can see the eyes are blinking, and when we ask, please stop it, he can do for a while. So that's tics. Tics is jerky. The keyword is suppressible. And one last movement is stereotypy. Some abnormal movement, complex type of movement going on and on and on. Like this patient has this perioral movement. So you can see that this patient has this sucking type of movement, kissing type of movement going on and on. That is stereotypy. So that was the whole spectrum of language of movement disorders. So I'll go on quickly. Tremor is rhythmic. Dystonia has some posturing. Myoclonus is jerky. Chorea is dancing. Tics is suppressible. And this stereotypy has a repetition of movement, right? So now I'll ask a sort of quiz, what movement it is. Just think of it in your mind. I know that's difficult, but to tell right now, but think of it in your mind. It's not rhythmic, right? There's no posturing. There's no jerky movement. It's flowing movement. It's a dancing movement. So this is chorea again. So the generalized chorea, the patient has NO3 mutation, rare condition, but generalized chorea. So these things we have to, as soon as the patient comes to us, we have to know very clearly that what phenomenon we are dealing with. Because once you, suppose a case of Huntington's come to you, has chorea, and you feel the patient has myoclonus, your all differential will be in different diagnosis, and you won't think of Huntington's. So unless the first step is right, you cannot go into the right direction. And that's why it's very important to understand the phenomenology. So movement disorders work mainly on phenomenology, mainly on the eyes. So without even touching the patient, you know that which direction you have to go. Now we'll move on. So approach to slow patients. So this was the coin of movement disorders. Now we'll talk about slow patients. So what I have thought that we have 4 or 5 key movement disorders. I'll talk about approach to each of them, time permitting. If time doesn't permit today, we can do some other day. But let's start with the slow patient or bradykinesia or Parkinsonism. So the usual story is that my patient has become slow. They come with that. But I'll warn all the clinicians here that we have disturbing tendency to diagnose Parkinson's disease casually. Somebody told that I have become slow because of depression, they may be. We may diagnose Parkinson's and start levodopa. Somebody can become slow because of some small strokes. We think of Parkinson's disease. So this disturbing tendency to diagnose Parkinson's should be avoided because the diagnosis is largely clinical. If you diagnose wrong, the patient will go to the periphery with the wrong diagnosis and keep on taking levodopa for a long time. I'll give one example. There's no shame in holding the diagnosis and see the patient again in a few months' time to have clear diagnosis, right? I'll give one example. He is my colleague employee. On a bad day, suppose he has bad day in office, somebody has shouted or scolded him, he can be slow or on the right side. On a good day, he can be fast. It's just a fun video to let you know that when you are depressed someday, when your day is not going well, you can be slow. When you're very happy, you can be fast. That doesn't mean that slow day you have Parkinson's and fast day you're normal, right? So that means there has to be some method to know how to diagnose bradykinesia, and that method is this. We call as a finger tap. I'm sure that a lot of you know that, but we ask the patient to open close as fast as possible and as wide as possible. I'll stop the video and please look at my finger. We'll ask the patient to open close, not like this, fast and wide, as fast as they can, as wide. And the best way to keep the thumb on the distal phalanx, like this, distal phalanx of index finger and middle finger, not like this. This is the best way to diagnose. And both hands should not be done at one point in time, because if you have bradykinesia, one side can influence other side by mirror movement. So only one side at a time, right, then left. How many times you have to see? At least 20 times, maybe 30 times. If you don't go up to 30 times, if you get bradykinesia, 10 times is enough, right? What we see here, we see 2 things. One is progressive decrease in amplitude. You can look at the amplitude. If I'm doing this all the time like this, I don't have bradykinesia. But when it started like this and gradually I become slower or narrower, means if amplitude reduces or velocity reduces or both, this is bradykinesia. One more time, somebody can maintain amplitude by reduced velocity, still bradykinesia. Somebody have velocity, but amplitude becomes smaller and smaller, still bradykinesia. So when we do finger tap test, we see both. We see speed as well as the amplitude, progressive deterioration, progressive reduction, wide, and you can see that he moves slow and slow. So this is bradykinesia for you. So the word progressive is very important. If somebody is slow right from the beginning and keep on same speed, that's not bradykinesia. If somebody has small amplitude right from the beginning and kept like this, is not bradykinesia. Progressive decrease in speed or amplitude is important. Why? Because stroke, mild motor neuron disease, a lot of other motor syndrome can lead to slowness without progressive decrement. So mild subcortical stroke can have slowness. Motor neuron disease affecting the hand can have slowness. So we have to see progressive decrement. That is only suggest of bradykinesia. Brady means slow kinesis. Okay. So suppose a patient comes to you and the family tells that my father has become slow. We ask the patient to sit. We see this on the hand and also in the feet, tap, feet tap, the feet on the ground and do this. And when we see the progressive decrement, we are very happy that we got the bradykinesia, we got some diagnosis. But is bradykinesia enough to diagnose Parkinson's disease? No, we need to have at least one more symptom, and that we call as UK Brain Bank criteria. That is tremor, rigidity, or gait imbalance. Either of the one only with bradykinesia, only then we diagnose as Parkinson's disease. So bradykinesia has to be there, plus either of the one. So you can imagine somebody with bradykinesia, with rigidity, Parkinson's, with gait imbalance, Parkinson's. So a patient may have no tremor, still the patient has Parkinson's disease. I'll impress upon one more time. Many times the patients feel that they need to have tremor to call Parkinson's disease. That's wrong. Parkinson's can happen without tremor also. And now this is full-blown Parkinson's disease, and you can see everything here. So patient has start hesitation. While walking, they freeze. The first few steps are very difficult. And then they start walking. This is a gait, right? That's a two-dimensional gait lab. And when you see, while walking also, stride length is small stride length. The ground clearance is less. Arm swing is gone. Arm swing is not there. And one side patient has this rest tremor. So these are all are features of true idiopathic Parkinson's disease, and generally they do well on levodopa, as you know. So we learned about tremor, we learned about bradykinesia, how to check balance. Patient may tell you that my balance is not poor, but early on they may not tell you. In that case, we do pull test. Again, pull test, clinical understanding what to do is very important. We stand behind the patient, and behind us should be a wall so that both of us do not fall on the ground, right? So we stand behind the patient, we hold the shoulder, and we tell the patient that I'll give a small pull. Don't worry, I won't let you fall. But suppose you are losing your balance, use your steps backward to stabilize yourself. Generally, you are in a firm pull. Patient takes 2 or 3 steps to stabilize, but more than that is pull test positive. That means balance is poor. That means chance of fall is there. You can see that my fellow asked to stand up, stabilize, pull, 1, 2, 3, 4, 5. So patient took almost 5 steps, and the pull was not too firm. So the pull test was positive. So pull test is the way to check the balance. So this is the way we diagnose Parkinson's disease. One thing we have not talked about is rigidity. Rigidity is stiffness, because very difficult to see rigidity from outside. Patient will tell you that I am stiff, very rigid. But if you have to say, shake hand, ask him to do to keep the wrist loose and rotate in all directions and feel the tone. The tone should be increased in all directions, unlike spasticity, where one side is affected more than the other side. So that's rigidity for you. Now, when we diagnose Parkinson's disease, the first thing I ask that give me all the medication list, because the most common cause, a very common cause of Parkinson's differential is drug-induced Parkinsonism. In India, some medications, antipsychotics or levosulfide is freely available that can cause Parkinson's-like state. So first thing is to do to rule out medication-induced Parkinsonism. The clue is that generally medication-induced Parkinson's is symmetrical. It may be asymmetrical, but generally symmetrical. But more than that, many medication-induced Parkinsonism has perioral mild movement without even starting levodopa. After you start levodopa, some dyskinesia may happen. But before that, if perioral movement is there, then it may be drug-induced Parkinson. Like this patient has, you can see some movement, some tongue movement is going on. And this is a case of levosulfide-induced Parkinsonism, who has Parkinsonism with some dyskinesia. Okay. The myth is that now we learned about Parkinson's features. We know that rest tremor means Parkinson's disease, right? So, but the myth is that rest tremor is Parkinson's all the time, and postural tremor means no Parkinson's. That's wrong, because many Parkinson's patient has postural tremor also and rest tremor also, like this patient. You can see that patient has clear postural tremor, keeping the hand in front. In the posture, tremor is happening. So this patient again, bad postural tremor. The lady has essential tremor, and the man has Parkinson's disease. How to differentiate that? Few clues. First clue is that there is asymmetry. Asymmetry goes in favor of Parkinson's disease. You can see that man has one side more than the other side. Second clue, prominent rest tremor. You can see that patient has postural tremor, but very prominent rest tremor also. Again, asymmetrical. And third is slower frequency. Generally, Parkinson's is course, 3 to 4 hours. There's another phenomenon. If you find that, then Parkinson's is very likely. That's we call as re-emergence. This is not re-emergence. Rest tremor is PD, very clear. And we call as pill rolling tremor. The hand pill rolling is there. This is re-emergence. You can watch the patient as rest tremor. When they bring the arms in front of them, this patient, the tremor was gone. So there's no postural tremor at this point in time. There was some hiatus and it came back again. So there's a re-emergence of tremor on the same side. The rest, no tremor, came again in same frequency, and that we call as re-emergent tremor. If the patient has re-emergent tremor, most likely Parkinson's disease. Okay, there. So you're diagnosed Parkinson's disease, but many times the patient might come to you, has Parkinson's feature, not responding to levodopa properly, and they are clubbed as Parkinson's plus syndrome or atypical Parkinsonism. So 2 or 3 conditions are there. I'll show quickly and then move on from Parkinson's. So this patient, when you see a case of symmetrical bad Parkinsonism, having vertical gaze, when I asked to look up and down, he could not do that. Maybe 1 or 2 times very slowly, he could not do that. So gaze was involved. And that is not seen in Parkinson's disease. That is vertical supranuclear gaze palsy. That is seen in PSP. Why supranuclear? When gaze is involved, patient cannot do that. Now ask the patient to stay fixed. And when you move the head ask the patient to look on an object, the eye will come down. So it's not peripheral palsy. Peripheral is good. One more time. Patient may not have any movement of the eye, but ask the patient to look at a finger and then move the head up and down, you'll find that eye is moving. So that's supranuclear gaze palsy. PSP patient has applause sign, as this patient has. We asked him to do 3 times, clap, and we'll see what's happening. 3 times, and he kept on going. That's the applause sign. That is in frontal dysfunction, and mainly in PSP and frontotemporal dementia. So that was PSP for you. So we learned about Parkinson's disease. We learned about one variety of atypical Parkinson's, PSP. The other variety is corticobasal degeneration, where one part is affected more than the other part, and they have dystonia. The hand becomes very dystonic. They cannot use the hand properly. We call it apraxia. They are useless hand. Means if they have to hold a glass, they cannot use through that. They use other limb. Apart from that, they have some myoclonus, jerky movement. So look at him. You can see that he has a case of asymmetrical Parkinson's. When you see profoundly dystonic, he cannot use his left hand. And we see closely, some jerks are there. Some jerks are there. Some myoclonus is there. So this asymmetrical or unilateral Parkinsonism with dystonia, with apraxia, not using the hand properly. Apraxia is the word we use when everything is okay, but you cannot, power is okay, but we cannot use the hand properly. Apraxia with myoclonus, that is corticobasal degeneration, again, a type of atypical Parkinsonism. Now over here, I will like to tell you about another Parkinsonism, which is very common in society, vascular Parkinsonism. Many cases of vascular risk factors, hypertension, diabetes, they develop small subcortical changes in the subcortical area that affects the legs and they have walking difficulty. In that case, upper limb is not involved. Upper limb is good. So arm swing is good. Only lower limb is involved. Some balance will be there and they walk differently. So this patient has vascular Parkinson. You can have a look. So he's not walking normally, slow. But look at his arm. Arm swing is well preserved. When you have this condition, the word we use is lower body or lower half Parkinsonism. Arm swing is preserved, face is preserved, only walking is difficult. In contrast to Parkinson's disease, you can see in Parkinson's whole upper body is also involved. But most important point I like to mark that in vascular Parkinsonism, the stance base between the 2 feet is wide. Parkinson's, that never happens. In Parkinson's, stance base is narrow or normal. But in vascular Parkinsonism, in ataxia, the stance base is wide. I'll like to show you one more time. Look at the stance base on the right side. When arm swing is well preserved, that is vascular Parkinsonism. Stance base is wide, upper limb is preserved. So this lower half or lower body Parkinsonism. Moving on. Now, we learned about Parkinson's and some atypical Parkinsonism, regarding treatment 4 or 5 slides, and then we move on to something else. The recurrent theme is the doctor, you're treating me for 4 years and still it's worsening. So right from day one, we have to tell the patient that we treat symptoms. Fortunately, there's no medicine to halt the progression. It will keep on worsening. We have to keep on upping the treatment, upping the medication, but there's no cure per se. Early Parkinson's disease, you give the diagnosis, may not need treatment. If the patient is managing well, may not need treatment. And there's some basic concept of treatment. Young age, you can start anticholinergic or dopamine agonist. Tremor dominant, anticholinergic can be started. Again, if the patient is young. Elderly patient, anticholinergic is not a good idea because this can cause dryness of mouth, cognitive problem. There are some subsets of young onset, they respond very well to anticholinergic for a long time. So there's no harm in trying at least for a few months' time. If above treatment not very effective, don't delay levodopa for a long time because levodopa is the best medication and that way improve the quality of life. Start levodopa. And razagalin can be started in the hope of delaying. Among all the neuroprotective medication, vitamin E, coenzyme Q, razagalin, this has some evidence, rest have no evidence. So razagalin can be started, especially in young onset Parkinson's, in the hope that it can delay the progression. But evidence is thin again. Now we already see many patients that they are suffering, they do suffer, but they don't want to start levodopa. They can start anything, but they want to save levodopa for the future because they have seen on the YouTube with dyskinesia, levodopa induced dyskinesia. So that's myth. Dopamine agonist and anticholinergic, they have more side effects. Anticholinergic, dry mouth, urinary retention, confusion state, cognitive decline. Agonist, excessive somnolence, hallucination, impulse control disorder, and punding. Punding is a type of close to impulse control disorder. And this was a case on pramipexole, and you can see in the night time, he wanted his bed to be so perfect that in 3-4 hours, he used to work on the bed. It was ill-fitting. He wanted to fit it.
Ada yang belum dibuatin
perfect.
ini. Aku chatting satu mau pulang ke catur. Tadi catur nggak sini, Pak? Catur Wulan dari.
So wife is saying that for 5 hours he is doing the same thing, repetitive motor behavior, and that's punding for you. And regarding treatment again, what I see that tendency to underdose when it comes to treatment of Parkinson's disease. We give, say, half tablet twice a day, half tablet thrice a day. Generally, that doesn't work. 3 to 4 times a day, 100 milligram. So 3 or 4 times a day. That's the dose which generally works for the patient. Levodopa plus carbidopa 100/25 has better efficacy. CR preparation, levodopa carbidopa control release, it has limited value because its release is erratic. So nighttime, one time, that's good, but daytime it has a limited value. Entacapone, like Stalivo, we used in the past, but now we have seen that efficacy is not that great and it causes more dyskinesia. And there's no consensus regarding highest dose. We have seen that we are afraid of increasing the dose, but if patient responding, we can go up beyond 1000 milligram also, and that helps the patient. So that's regarding levodopa treatment. What happens in levodopa that Parkinson's time passes by? You can see wonderful response to levodopa that lasts for 4 to 5 hours. That's honeymoon period. But as the time passes by, patient develops either on-off phenomena, means quick on, 2 hours, 3 hours, less than 2 hours, or dyskinesia after taking the medication. That is dyskinesia. So on-off phenomena, strategy should be increase the frequency of levodopa. We can add entacapone, razagalin, dopamine agonist, amantadine. Morning off, I prefer to give very early morning. I tell the family members that wake him up, give him 1 tablet at 4 or 5 a.m. And by the time he gets up, he will be okay. And DBS surgery, of course. Dyskinesia, mild dyskinesia is more troublesome for the family members, but not for the patient. Mild dyskinesia, there is no need to treat. Moderate to severe dyskinesia, of course, we have to treat. Like this is one of the worst dyskinesia. The video is not there, but worst dyskinesia. Then you can add amantadine. That's one of the good medication. Clozapine also works, and reducing the individual dose of levodopa works, and DBS surgery works. So finally, levodopa, myths levodopa is bad boy. Start as late as possible, but if the patient is losing quality of life, start early, and patient will be helped. Myth of drug holidays. Sometimes I have seen in some of the clinics, to diagnose Parkinson, they suddenly stop levodopa to see whether patient's symptom come or not. And after stopping levodopa, you might have such symptom. Whole body may become very stiff. So, and this can cause a troublesome condition, acute dopamine deficiency syndrome. So don't stop levodopa suddenly. And finally, we have seen many patients of Parkinson's disease, they maintain well for some time and then start having rapid deterioration in Parkinson's disease. Generally, Parkinson's patient, it doesn't go rapidly. If rapid deterioration, that means something is there. And that something can be some missed dose of levodopa, dopamine antagonists like levosulpride or antipsychotic, weed out unnecessary medication because they may interact with each other. Electrolyte imbalance can cause a sudden worsening, and sepsis can cause a sudden worsening. So that is a scenario when your patient comes with sudden worsening, we should think about that. And subdural hematoma, sometimes we miss, thinking that everything is Parkinson's disease, and subdural hematoma we will miss. So this is the final slide of Parkinson's. Young onset, try anticholinergic and dopamine agonist. Older patient, try levodopa. Don't be shy of levodopa. Simplify regime, less is beautiful, and levodopa dyskinesia, amantadine is can be given. DBS for selected patient, and I think DBS I won't talk about that because. So this was regarding Parkinson's approach. Regarding DBS, if you have in your country, I'm sure that many centers have. A selected patient works wonderfully. Like this patient was off before DBS, and few days later after DBS on same dose of levodopa, you can see the difference. DBS, deep brain stimulation surgery. It should be done in those patients which are not demented, which have on-off phenomena, maybe peak dose dyskinesia, but still response to levodopa. They do well on DBS. So Parkinson's is a journey for more than 200 days, a lot of things to learn. And that's regarding approach to bradykinesia, which we learned about Parkinson's disease, its treatment. We learned about PSP, CBGD, and some other variants, vascular Parkinsonism. So that was Parkinson's. So it's only 45 minutes. If we have time, we can go ahead with other movement disorders also. I gather that we have about 2 hours time. Are you okay with that, or should we stop?
You can continue with other movement disorder lecture, Prof.
Okay.
We
So
still have
what I'll
time.
do, yeah. So what I'll do, I have 3-4 talks regarding approaches. In short, I will tell you. First, I will do approach to gait, because gait is very important. If the patient comes to us, the first thing we see how they are walking to us, isn't it? So through the gait, we can diagnose quite a lot. So we'll talk about gait. Then we have chorea. These two I like to cover, and if you have time, we can cover more. So let's go to the gait. Give me a minute. Okay, this is regarding gait, and this is very important for our part of world because we are overworked. So if a patient comes to us and we have fair idea by just seeing the patient, we can use our time efficiently. And we have learned from our ancestors and from our senior medical colleagues also that they used to be some very brilliant clinician. By just seeing the gait, they used to diagnose. So I suggest the student to keep an eye on this. Keep a very keen eye on the gait. There's some patterns I'll tell you, and that will help you diagnosing the patient even before you have touched the patient, before you have talked to him. Gait is very important. In fact, we talked on all four long back, millions of years back, and getting on 2 was very important because then you started to use our hand for doing all of the work. Just imagine how it would be when a patient has to walk or person has to walk on 4. So this is a condition known as Öner-Tan syndrome, which is described by Turkish clinician Öner Tan, and the patient walks on all 4. So it's very difficult. Then you cannot use your hand properly. So this was to impress upon gait is very important. Patient's gait is trying to tell you the diagnosis, whisper diagnosis in your ear. So you have to see properly and you will know the diagnosis. Walking is a symphony of neural orchestra. So whatever you walk, it is a brain, spinal cord, peripheral nerve, muscles, bone, all together, they walk. So the clinician, your eye should be like conductor of orchestra. So when a conductor of orchestra is there, he knows that which violin is not working well, which cello is out of tune. So that exactly you have to see. Just by seeing the walking, you should know that which part of your axis is involved. And I like to suggest few clues here. Hold on, it's not okay. Yeah. So out of this, the most important clinical guide, hold on. It is jumping. Give me 1 minute. Let me sort out the slide because it's jumping itself. Yeah. So what I'll tell the student that when a patient comes to you, examine gait. And there are few headings for that, right? So examine gait, see the gait pattern, see the neuraxis
I'm sorry,
involved.
Prof. Kumar. The slide
It's not
still
all right.
still
All
not
right.
appear
I'll
in the
stop share.
screen.
No worry, no worry, no worry. What about, is it appearing? No. Not yet, right?
Yes, it is in screen.
Okay. So gait sense, right? This slide. Okay. So what I'll tell the students, so think of these 4 things. Examine gait for few minutes. Think of a gait pattern. I'll talk about everything. Think of neuraxis involved and then possible etiology. So most important guide, if you have to no, is the slide okay? Is the slide okay now?
Yes,
Yeah.
the slide is
Okay. Okay. So most important thing is to see the distance between the 2 heel while walking. Somebody can walk with narrow stance, somebody can walk with wide stance, and both are different. To that, we can know clinically what it is. Look at the difference. This is narrow base. And this is wide base. One slide is not moving, so forget about one video is not working. But this gentleman has CBGD, corticobasal degeneration. You can see the base was wide. Another has Parkinson disease. Unfortunately, video is not moving, but I can tell you. So Parkinson's patient comes to you with wide base. That's a red flag. That's not Parkinson disease. That can be something else. That can be PSP. That can be CBGD. That can be vascular Parkinson's, but not true Parkinson's. But true Parkinson's is narrow base. This patient is CBGD because you can see the arm posturing. Hand is postured like this. Right hand is postured like this. Dystonic. So stance base is very important. All right, our stance became narrower with time, elegant but less efficient because balance has become poorer with evolution. So how do we examine clinically? Everything. We see the patient seated position, how they are sitting, they're tilting on one side, they are moving on one side, they are stooped forward. When they stand from seated position, do they stand in one go or take multiple attempts to stand? Do they stand with the feet in front? When you stand, you have to take feet in front of the chair. You cannot stand with the feet going inside the chair. Then you cannot stand. So feet in front of chair. While standing, they are standing erect or they are swaying like this or they're tilted on one side. While walking, they have what is the walking stride length, means the step length, whether they're slow or fast. While turning, we see that whether they freeze or not on turning. And we do some maneuvers like tandem walking, backward walking, running, walking on toes, walking on heels, walking on queue. So these are headings of clinical examination of gait. And I'll show one quick video for all them. You can see the patient takes a lot of effort to get up. He doesn't have myopathy. He has Parkinson's disease, but a lot of effort to get up. So first thing that how many attempts he takes to get up from the sitting position, that itself should be noted. So gait examination starts from the sitting position. While standing, you can see, you have to see that whether they stand with a wide stance base or narrow stance base. They have, when they stand, they have instability, they try to fall. With the excessive sway, leaning one way, truncal flexion, and you can see that all differential is there. Narrow stance is Parkinson is spastic paraparesis. Wide stance we talked about in vascular Parkinson's plus syndrome, ataxia. Instability, orthostatic tremor. Excessive sway, ataxia or dyskinesia, sometimes functional also. Leaning one way, skeletal or pizza syndrome. Flexion truncal, skeletal or camptocomia. So just by seeing the standing, you can fix some differential diagnosis. Right?
डाउनलोड नहीं है ना
This patient has start hesitation, which can be seen Parkinson's disease and orthostatic tremor. On this video work here, you can see narrow base, leaning on one side, arm swing is not there. So now we are seeing walking. We saw standing, sitting, getting up, and walking. Sometimes freezing sudden stoppage may not be obvious while walking, but when they ask the patient to turn around, we saw freezing. You can see when the patient is turning around, he takes a lot of steps. So it's very important for us to see not only patient in one go, to turn around and come back, and sometimes freezing can be seen during turn. And during walking, what we see, how they start the steps, what is the stance base, posture is erect or forward posture, which is in Parkinson's, backward is in PSP, speed and cadence, trunk or arm movement, reduced arm movement is in Parkinson's, step length small, and trajectory means they are clearing the ground properly or not. Clearing the ground improperly, Parkinson's disease. In case of foot drop, high steppage gait. So these are the points which we see in case of Parkinson. Pull test we talked about, but to see the parents, we do pull test. So that was gait examination. So you have to do gait examination sitting, getting a standing up, how they are standing, how they started to walk, how they turn around and set. So that is the way we examine. And then we have to recognize pattern. I'll show you 3 or 4 patterns. One is very important to recognize these patterns. That is ataxic, bradykinetic, dystonic. There's a thing known as higher level gait disorder and spastic gait. And well, suppose you put ink on the feet of patient and ask them to walk, this will look like this. And spastic number 2, you can see that narrow base and crisscross. Short stride length, narrow base, crisscross. Ataxic, wide base, but if they're swaying, and more than that, step length keeps on varying. Sometimes 1 feet, sometimes 6 inches, sometimes 3 inches, sometimes 9 inches. So a step length keep on varying. That is ataxic gait. In Parkinson's gait, again narrow, they are short, shuffling gait as we know, and frontal gait. Contrast this with ataxic gait. Ataxic is also wide base. Frontal is also wide base. Frontal is higher level gait disorder. They're also wide base. In ataxic gait, the stride length sometimes more, sometimes less. In frontal, it's all the time small, and that is seen in normal pressure hydrocephalus, also seen in vascular Parkinsonism. That's frontal gait. Now, what is the gait pattern? You can see wide-based swings, and this was long step, again short step, sometimes long, sometimes short step. That's ataxic gait. So pattern recognition is important. By seeing this, it's very easy to diagnose ataxic gait. Bradykinetic we have shown many times, so I won't show this. This again is bradykinetic gait. You saw that narrow base, short stride length, shuffling gait, bradykinetic. Another bradykinetic. Over here, you can hear, sometimes you can hear the patient walk. They shuffle, they scrape the ground. When you're hearing the patient walk, that means Parkinson's disease, and normal pressure hydrocephalus, they scrape the ground. So that can be seen. Spastic pattern, difficult sometimes, but you see that whole leg to be too rigid, too stiff. The knee is flexed and it remains flexed while walking. Generally, what happens with each step, we feel that it should be straightened up, but it remains flexed while walking. That's spastic gait for you. This is another spastic gait. This patient has mixed ataxic, you say ataxic gait, and hand is in dystonia. Part of foot is dystonia, dystonic gait. Ataxic dystonic gait. Now coming to concept of higher level gait disorder, some patients, the upper limb is free, as you saw, but lower limb, they shuffle quite a lot. And generally this is seen in case of vascular Parkinsonism or in case of NPH. Now I just want to show one thing, that some case of higher level gait disorder, they tilt toward one side. In case of vascular Parkinsonism, if one side is more involved, other side is less involved, they tilt towards one side. You can see that all the time they're tilting towards one side. is a type of higher level gait disorder where parietal lobe is involved and tilt over. The reason is that they don't know what is the vertical. So all the time, the body doesn't know what is the vertical, they're tilted toward one side. In case of Pisa syndrome, also tilt is there, but Pisa syndrome tilt is from the abdomen or from the lower back. In vascular Parkinsonism, the tilt is from the feet. And vascular Parkinsonism is a new term, or lower body Parkinsonism is a new word, and it encompasses a lot of things: gait apraxia, arteriosclerotic Parkinsonism, frontal ataxia, Marche petit pas, sleeping clutch syndrome, magnetic gaits. This all is part of vascular Parkinsonism. All right. In our country, some cases we have SSP, subacute sclerosing panencephalitis, where myoclonus is prominent. And you can see that this patient, while walking, sudden myoclonus came and they stopped. So myoclonic jerk affecting force. Walking, sudden myoclonus came on the feet and they stopped. So this was gait for you. First of all, you have to examine gait in all scenarios: sitting, getting up, standing, starting walk, walking, turning around. Depending upon that, you fix the gait pattern. You see the neuraxis involved and possible etiology. If gait pattern is spastic, that means pyramidal tract. If gait pattern is ataxic, that means there's cerebellum or outflow tract. Bradykinetic, that means basal ganglia. And depending upon that, we go for etiology. So defining gait pattern is very important, but some gait pattern is very difficult to define if they're functional, like this, especially historical video. You can see that bizarre crisscross and then sudden flexion of the trunk, some movement of the arms. This is a classical functional gait, and this is another functional gait. They start bouncing suddenly, and this bouncing gait is generally in functional gait. This is all again functional. They fall, but they fall in a way that they don't hit themselves. Walking, fall. They know that they are falling. They bring their hand. They don't hit themselves. And functional gait, I found pull test is very useful, because pull test, seemingly pull test is involved, but they can balance very well. Yes, it looks like they will fall, but they can balance very well. When they find that you're not in the behind, they balance themselves. Yeah, this functional again. So this we already talked with, because CBGT was there. And let me see what it is. Yeah. So do we see some difficulty? So first of all, not wide-based. So no ataxia, no lower body Parkinson, no NPH, narrow base. It can be Parkinsonian, but I'll tell you the diagnosis. The patient is quite stiff. When you see the lower back, there's lumbar lordosis, and patient has stiff person syndrome, and they walk like this. So the point is that sometimes stiff person syndrome this is antibody positive, can look like Parkinsonian or spasticity, but you have to see the lumbar spine, lumbar lordosis, and history is quite evident that the patient has pain and stiffness in the lower back. So that was gait for you. And for caregivers, couple of clues to prevent: extend arm on the side to keep balance while walking. Balance is very poor. Extend arm a bit and keep your gravity in both legs. And if you fall backward, tuck your chin so that head won't hit. So bring your chin forward. This we say. And thank you very much. This is regarding gait. All right. So I will stop for a couple of minutes. Any question in Parkinson's or gait? I showed gait because gait is very close to Parkinson's disease. Any question from audience? I'm happy to say. And I think it's 12:35. It's 1 hour almost, but I can at least one presentation I can give regarding Korea, because Korea is very difficult, and then we can see how it goes.
Okay, before we move to another lecture with Korea.
Fine.
Okay.
Yeah.
Is there any question from the participant? If you have any question, you can use the raise hand in the Zoom, or maybe you can anyone in the spinal hall, maybe you can ask directly to Prof. Kumar. Is there any question from from the participant?
Share Korea in the meantime.
Oh, okay. Okay. This is a question from Dr. Banon. How can we differentiate?
Yeah, yeah, I read that.
Sorry.
I read
Oh,
that.
yeah.
Yeah. So this is very, 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 very good question. I would say that means the person who's asked question, they are seeing a lot of patients of Parkinson's disease, because many times we get confused between tremor dominant Parkinson's and dystonic tremor, right? So in dystonic tremor of hand, you will have similar tremor, but one cue is that in tremor dominant Parkinson's disease, all the time the movement will be regular, rhythmic. In any dystonia, sometimes you have jerky movement of the hand, right? So dystonic tremor is never rhythmic. The jerk will come. That's one. Second, of course, posturing of the hand. If the patient has in tremor dominant Parkinson's disease, you have Parkinson's, you have mild posturing because it's flexed, but not abnormal posturing. Abnormal extreme posturing with tremor, that means dystonic tremor. But sometimes posturing is so mild, so confusion happens. In that case, one good guide, as we discussed, is jerkiness. Rhythmic all the time, this is not dystonic tremor. Some jerkiness, that is dystonic tremor. But very good question.
Okay. Is there any question? Because we will continue with the Korea topic. Prof. Kumar, before we move to Korea topic, maybe I want to ask a little, because you say we have to start levodopa immediately to Parkinson's disease patient if the other agent is not really
Yeah,
effective. Is there
yeah.
any tools or any how to define it is not effective objectively to a patient with other regimen
Yeah.
aside
Yeah.
the
So
levodopa?
again, these are wonderful questions. I'm very glad that these questions are coming up. So first thing, when I told, first of all, levodopa should be started immediately, means I wanted to say that if we should start with agonist in young patient, we should start with anticholinergic in young patient with tremor. We should start with levodopa in elderly patient directly. Means if suppose somebody is 75, 77, there's no point going for dopamine agonist or anticholinergic. So this is the first thing. Then you asked a wonderful question that when we are trying, say, anticholinergic or dopamine agonist, how to know that it has worked or not, right? So in that case, a few things. First of all, functional is very important. We'll ask the patient whether they have improved in function or not. But I generally do UPDRS 3. It takes hardly 10 minutes, 5 minutes time to do UPDRS motor score. If motor score is not improving in the subsequent one or two, then we move to levodopa. Only after asking in fact, when we start even dopamine agonist, we ask the patient that do you really need treatment? I know that you have mild tremor, but can you manage your daily activity with this? He tells, fine, I can manage that. I don't start any medication. But once we start the medication, these two agonists or anticholinergic, we see for 6 months or so. If no improvement, then we discuss about that. And then you ask about dose. What dose we should go before thinking that, yes, this is enough. I would say in case of anticholinergic and in case of dopamine agonist, both have different dosing, as we know. Anticholinergic 2 milligram of trihexyphenidyl was R10 2 to 3 times a day, that suffices. If 3 times it's not working, there's no point going up and up. Higher dose can be tolerated in children, but not in adults. So if the patient has to respond, 2 milligram, 3 times 6 milligram is enough to know if the patient is responding or not. So that's regarding anticholinergic. Regarding pramipexole and ropinirole, pramipexole 1.5 milligram 3 times a day, that is 4.5 milligram or 6 milligram in a day. That suffices. That if they're not responding, they won't respond. So that was, I think, to answer your question. All right.
Okay, thank you, Prof. Kumar. Is there any question from the participant, or maybe we should move to other topic with the Korea topic? It is interesting topic too. Okay, maybe we can begin with the move to other topic with
All
the
right.
Korea
All
topic.
right. Well, when we talk of Korea means chorus, chorus. Chorus, yes.
I'm sorry, the
Slide
PowerPoint
is
is
not there.
still not.
All right. I'll try again. This playing games. Let me try one more time. Yeah, is it visible now?
Yes.
Yeah. I'll do full screen. Now this, I'll give a little local flavor to this. Korea is the name, came from Greek. Korea means dance. So this is a dancing movement, right? And it is so mild sometimes that difficult to understand the patient has chorea or they're just anxious or nervous. So in one of I call it Nawab Jan of all movement disorders. You may not know Nawab Jan. Nawab Jan was a well-known court dancer in say 300 years back in India, and she was very subtle. She used to dance very well. And one poet was there, Mirza Ghalib. He has wrote a lot about that. So you don't have to go to the history. I just wanted to know Korea is like dance, real fluid, beautiful dance. Let's start with the name itself. The name itself rings beauty. Korea versus Tremor Dystonia. Korea it sounds good. Korea name is derived from chorus, that is dance in the Greece. And this is one of the historical picture of Saint Vitus dance or rheumatic dance where the patient had Korea. Korea, I'll give Korea, say, a female name. Korea is so tremor. Think of Korea as an individual and think of Korea as a female, right? She's nervous, she's subtle, she doesn't shout at you, she doesn't stare at you. Why I'm saying so? If a dystonia comes to you, it stares at you. I'm dystonic. See, I have a movement. If tremor comes to you, it is shouting that I have tremor. But Korea, you have to find out. You have find out whether the patient has Korea, especially in the mild Korea. Okay, so she doesn't shout at you, she doesn't stare at you. Subtle chorea, maybe mistaken nervousness, as I'm talking about. In some patient, what you have to do, you have to distract the patient to bring the chorea out. And the one way to distracting the patient, to ask the patient to count backward and outstretch the hand. So to bring the chorea out, we ask the patient, okay, count backward. He has, say, minimal chorea, which was not obvious. What he is doing right now, he's counting. He's counting.
Prof. Kumar? Prof. Kumar? Do you hear my voice? I think it is freeze. Oh, I think
I
that's the
think
problem.
no, I came back again. I think
Okay.
I somehow we lost the connection, but I came back
Yes.
again. I will share the screen again. Clear? Yeah? Okay.
Yes, it is
Yeah.
in.
So what happens that Korea, it tries to hide herself. So when you ask patient that something is happening, patient will tell no, nothing is happening, and they incorporate that movement into some other activity, what we call as semi-purposeful or semi-purposive or quasi-purposive. We talked about that. Like this patient, she has bad Korea, but when you ask anything happening, so no, nothing is happening. And the Korea, she tries to incorporate into adjusting the shawl or stole. Korea adjusts the stole. So that is semi-purposeful movement of Korea. Okay. Moving on, it is unpredictable. Sometimes hand, sometimes leg. So it's not only one, like Parkinson disease, you see, you have tremor at one place. In cervical dystonia at one place. But Korea, sometimes hand, sometimes neck, sometimes leg. So it keeps on fleeting, keeps on moving. You cannot guess what she is going to do next. Korea is going to do next. Sometimes the patient comes to you, have mild Huntington's or early Huntington disease, chorea may be hiding in the shoes. So you have to, when you examine the patient of chorea, exposed at least feet, sometimes they start in the feet. Irony is that it looks smooth from outside, but when you see very closely, they are not smooth. Chorea is mixture of multiple jerky movement and looks smooth. So subtle movement, they look smooth. And that's why chorea is among the jerky hyperkinetic. But jerks are so small and one after other jerk comes, so it looks like this is smooth from outside. So look at this gentleman, and you can see that movement. It was not smooth. One jerk, small jerk, and they all look like they have a smooth movement. He has Huntington disease. When you see closely, some jerk, see the jerk was there. Some jerky movement is there. So close to myoclonus, not as fast, but close to myoclonus, some jerky movement, and then he incorporates in some activity. So chorea itself looks smooth from outside, but deep inside it is mixture of multiple small jerks, and that leads to chorea. Chorea doesn't like company. You have learned about, when you see a little more about movement disorders, the differential diagnosis of Parkinson's plus dystonia, Parkinson's plus ataxia, but chorea plus Parkinson's, very little. Chorea plus ataxia, very little. Chorea generally stays alone. She doesn't like company. She wants to be left alone. But in some cases of some patients, what happens, they start with the chorea and gradually they turn into bradykinetic or dystonic, as happens in Huntington disease. When you see the early HD patient, they start with the chorea, and in many years' time, they can turn into, when you see, they're classically more of bradykinetic, more of dystonic rather than chorea. Like this patient, Huntington disease, if you see right now, hardly there is any chorea. It has more of slowness, it has more of dystonia, little bit of chorea in the hand, hardly any chorea. So a choreiform disorder in advanced case, they generally turn into Parkinsonian or ataxic syndrome, and chorea loses its character at that time. Now, time to define chorea. We saw various aspects of chorea, how to define it. This abrupt, non-rhythmic, irregular, flowing movement, unpredictable. This is non-stereotype. You cannot imagine that where it will come. Rapidly flits from one region to other region. Looks like continuous random flow of muscle contraction. So that is the definition of chorea. Sorry. So once the patient comes, through the definition, through what you saw in the video, you know that, okay, this is a case of chorea. Now, how to diagnose? What is the definition? What is the reason for chorea? For that, the simple formula that any patient, any children come to you, child with chorea come to you, or adult with chorea come to you, rather than going into deep details, a lot of algorithm is there. First thing to do, that in children, always think of Sydenham chorea. Always, especially in Asia, always think of Sydenham chorea. Only then think of anything else, because that is common, that is treatable, and we should not miss that. In adult, always think of Huntington disease first. If there's some history, some family history, always Huntington disease first. So this chart should come to our mind as soon as we see the patient of chorea. Sorry, I'm sorry. Okay, and what is left is non-Sydenham and non-Huntington's disease chorea. So in children, Sydenham and non-Sydenham. In adult, Huntington's and non-Huntington's. So that is the basic framework, and from this framework we will go ahead. Sydenham chorea. This is one of the case of Sydenham chorea. ASO titer was high. And again, if somebody says they may feel that the kid is just nervous, nothing else. But this vaccine and veins, now it has become a little more, and patients has some sore throat, cognitive issue early on. This Sydenham chorea for you. The myth is that Sydenham chorea is already in the developing world, but in developed world also Sydenham chorea can be seen. The myth is that only kids have Sydenham chorea, children have Sydenham chorea, but it can be seen in adult also, and it can be asymmetric also. This is one of the case of my fellowship days from Canada. Asymmetrical limb chorea and some tongue chorea was involved. So Sydenham chorea we have to keep in mind in children for sure. In adult also we should keep in mind. Okay. Now I'll go a little slow here because this is proper slide for the students, and they can see this. Once you have child or infant, you have ruled out Sydenham chorea, then see the family history: autosomal dominant, recessive, X-linked, or sporadic. Dominant, these are the differential diagnoses: GLUT1 deficiency, benign hereditary chorea. So dominant, if paroxysmal, it comes and go, GLUT1 deficiency syndrome. Continuous, benign hereditary chorea. Autosomal recessive, if you see MRI, iron is there, that means NBIA. No iron deposition, that means infantile and metabolic conditions. They're generally also recessive. X-linked Leishnian, if the patient has X-linked, Leishnian is commonly seen. You see uric acid, high uric acid, Leishnian syndrome, hand wringing, Rett syndrome. Others are metabolic mitochondrial conditions. Sporadic, the same in adult as well as kid. Abnormal MRI, vascular, infection, tumor, post-hypoxic. Normal MRI, metabolic, drug, autoimmune, paraneoplastic variant CT. So when you see the chorea differential diagnosis, they're big charts, difficult to remember. But this chart looks easy to me, and this covers about 80-90% of chorea. Sydenham rule out child, autosomal dominant, GLUT1, BHC, recessive, NBIA, infantile metabolic disease, X-linked, Leishnian, Rett syndrome, other mitochondrial, and sporadic, vascular infection, tumor, post-hypoxic, metabolic, drug, autoimmune. So this chart will guide you in knowing the differential of chorea. I'll show one or two cases of chorea. This patient has young onset, seizure, chorea, general movement, and sometimes this chorea or dyskinesia, this worsens quite a lot. One of the condition where he is more dyskinetic, swing towards both sides. And these are episodic exacerbations. So young patient having episodic exacerbation of chorea with history of seizure. You can see the legs is flinging all over the places. The GLUT1 deficiency should be kept in mind. One way to diagnose is genetic, but another way, easy way, is to diagnose through CSF sugar. Sugar level is generally low in this SLC2A1, that was GLUT1 deficiency. All right, so that was non-continuous. Autosomal dominant, chorea in young, continuous, benign hereditary chorea should be high on the list. Clinical setting, early onset chorea, hypotonia is there, tone is less. Generally benign course, they keep on worsening very slowly or they are stable. Mutation in thyroid transcription factor TITF1. They have hypothyroidism, they have pulmonary problems like brain, that's why we call it brain lung thyroid syndrome. And patients have early onset chorea, have some pulmonary, some cough and breathing difficulties sometimes. This is chorea. And the second video is to impress upon that this remains static after some time for almost whole life. So you can see this elderly lady having chorea. So BHC, benign hereditary chorea, remains static for whole life. They're continuous. Unlike GLUT1, they're continuous. And hung up reflex can be seen here because of hypothyroidism. Moving on. So we talked about autosomal dominant. Sydenham chorea ruled out, autosomal dominant, autosomal recessive. First step is to do MRI brain. Iron deposition, that means NBIA, some form of NBIA. No iron deposition is metabolic disorders like phenylketonuria, glutaric acidemia. And coming to X-linked, hyperuricemia, Leishnian syndrome. No hyperuricemia, Rett syndrome. We saw that earlier. Sporadic young onset chorea. Again, MRI is very important to rule out vascular infection, tumor, post-hypoxic. Normal MRI can be seen in drug autoimmune. They can be abnormal also, but normal MRI can be seen there. In Wilson's disease, I don't know if they're in your country or not. In my country, Wilson's disease can present like anything. Generally, they present with tremor and dystonia, but chorea is also common in Wilson's. Up to 9% of Wilson's disease patients may have chorea. Any new onset movement disorder in young, Wilson's disease should not be missed. A new entity has come up where young onset chorea with some dystonia. So chorea, dystonia, myoclonus, Parkinson's mixture young onset. Why is important to know? Because they respond to caffeine. Adenyl cycle is involved. They respond to caffeine. After taking coffee, they're much better for quite some time. So that ADCY5 mutation for you. So that was child. I'll show this chart again. I won't read through this chart again. You can see that basically we have covered more or less, or we touched upon everything. Now coming to adult, SD has to be ruled out. And non-SD, autosomal dominant. Adult, we are talking about adult. If the patient has ataxia, SCS 17, 1 and 3, African ancestry, SDL2, MRI iron is there, then neuroferritinopathy. Others, the benign hereditary chorea can be seen in adult also. DRPLA, C9orf17 mutation. Recessive, MRI has to be done again. PCAN or other NBIA can present in adult also. Wilson's can present in adult also. Acanthocytes, elevated CK, chorioacanthocytosis, X-linked, very limited, macular syndrome. In Filipino group, Lubac syndrome. others are mitochondrial, and sporadic are exactly the same, what we see in the kids, in the children. HD, we have to touch upon HD to some extent. HD is very prevalent in Southern America, especially in some cases of Venezuela. And this gentleman, Americano Negrato, in 1955, he went to US and presented his lot of cases, about 54 cases of chorea at that time. At that time, it was not known that whether the patient has genetically proven Huntington disease. He thought of HD. In local language, they call as bad air, bad omen for the patients. And a group from US came back to see his cases. When Nancy Wexler was there, she was a psychologist. She saw a lot of patients and she brought SD collaborative group. They took blood from 5,000 patients and gene was hunted and they found the gene. Clinical presentation, triad of symptoms, typically chorea, motor symptom, cognitive impairment, attention and emotional problems, psychiatric features, apathy, blunted affect, depression. And chorea may subside with time, and motor features may evolve into Parkinson's or ataxia. Language generally preserved, but motor speech is affected. Gait imbalance, fall, peculiar bouncy gait, they all can be seen in HD. And this lady is, which we showed earlier, classical case of HD. Semi-purposeful movement is more in HD as compared to any other chorea, and she has very clear semi-purposive movement. In this case, you can see the chorea is not easy to find. What you find that he walks with sudden flinging of arms as if he's too careless. And sometimes sudden fling of leg. So in this case, chorea is more proximal. There's more flinging movement and feels that he doesn't care anything, but that subtle chorea, which we have to diagnose. And this I showed that chorea may be replaced by slowness or dystonia in due course of time in case of HD. They all are HD. So that was HD. So we talked about adult. First thing, we should not miss HD, especially family stays there. We should not miss HD at all. We have to do HD gene test, or at least we have to do CT scan or MRI to see caudate atrophy. Another scenario, you have triad of generalized chorea, cognitive decline, psychiatric symptoms. So you feel an autosomal dominant history. You are very confident that patient will have HD, but you did test and it was not there. SD was not there. It was CAG repeat was normal. So the word we use is HD phenocopy. They look like HD, but they're not Huntington disease. And this is one of them. African ancestry. You can see chorea there. You can see chorea there. You can see some perioral movement, tongue protrusion. She had motor in persistence also. She could not keep the tongue outside for a long time, which is in HD. So everything was looking like HD. She has family history, but HD was negative 2 times. And further gene test was done. She is a case of a rare condition, junctophyllin gene abnormality known as HDL2, Huntington disease like 2. So HD, if not that, the word is HDL. Now look at this chart again. So if you have clear suspected HD, 99% case you are right, but 1% case you may be wrong, and that we call it SD phenocopy. Out of the SD phenocopy, only 97% we cannot diagnose at all, and 3%, this is old, about 15 years back, but 3% you can diagnose by various tests. There's prion disease can be there, Friedreich's ataxia can be there, SCA17 and SGL2. As the time has passed by, we have found that apart from those conditions, C9orf17 mutation, SCA17 also look like HD. So first thing we do to rule out C9orf17 mutation, SCA17. This is a rare condition, but and then if the patient has HD phenocopy, C9orf17 is ruled out, SCA17 is ruled out, but patient has ataxia or peripheral neuropathy, SCA1, 3, Friedreich's ataxia. Dementia maculosa, prion disease or mitochondrial disease. African heritage, SGL2, junctophyllin gene abnormality. Seizures, DRPLA. Abnormal blood film, neuroacanthocytosis. Abnormal MRI and BIA. So this is a sort of chart. If you are very sure that patient has HD, you find SD is negative. This is the way to go ahead in case of SDL or SD phenocopy. So we'll just revise that. Non-SD chorea, dominant, ataxia. I'm just revising it. I'm not reading everything. Recessive, pecan, acanthocytes, X-linked, maculoid syndrome, Lubach syndrome, mitochondrial, sporadic, lot of conditions. And few words about neuroconscious condition. This is mainly two types, choreocomcytosis and macular syndrome. They may mimic HD. They look like each other. One is X-linked. One case of neuroconcytosis. The giveaway is the perioral movement. In case of neuroconcytosis, apart from all chorea, generalized chorea, you have perioral movement and sometimes injury to the lips and feeding dystonia. While eating, tongue goes out and they are feeding dystonia. So that's neuroconcytosis for you. Coming to a sporadic condition or non-genetic, we have enumerated it. I'll show one or two videos. This is again quite common if you go to ICU and the patient is admitted with sudden onset hemichorea, especially elderly, especially females, never miss hyperglycemia. So hyperglycemia is one of the common cause, non-ketotic hyperglycemia, one of the common cause of acute onset hemichorea or hemibalismus. And they respond very well to just glucose, improvement in glucose. Another metabolic condition that can lead to chorea is chronic acquired hepatocellular degeneration, hyperthyroidism, hypoglycemia also can do that, renal failure can do that. That's chorea. Vascular chorea, acute stroke can present like chorea, but little too vigorous chorea, little too proximal chorea, and the word we use is hemibalismus. So chorea hemibalismus is semantics. Chorea is generally distal, hemibalismus proximal, more flinging movement, that's hemibalismus. It's more common in Asians with history of diabetes. Long-term prognosis is good. You can see that this both have a stroke. One has bleed, one has infarct, and hemibalismus is obvious. So acute onset, one side chorea, hyperglycemia one, and then vascular is second. Infection, tuberculosis, syphilis, HSE, herpes encephalitis can do that. HIV can do that. Drug-induced chorea, it's very common nowadays. OC pills, levodopa. Levodopa can cause dyskinesia, more of coriform. Drug that may induce chorea without pre-existing basal abnormality, like dopamine blockers, for example, flufentrixol or Senin. And full list of drug is there, but I won't read that. But it's very important if a patient comes to you with chorea, drugs are very important to rule out because it's easy to treat them. And again, drug-induced giveaway. In case of antipsychotic, levosulfide, perioral movement, mild we'll find, but you'll find it. In case of levodopa-induced dyskinesia, perioral movement is less. They have more of body movement. They have more of limb movement. Yes, it's subtle movement, perioral, tongue movement. And in case of levodopa-induced dyskinesia, they have not this perioral, they have more of limb movement. So that was the approach to chorea for you. Children, don't miss Sydenham. Adult, don't miss Huntington's. And rest all falls into place. So thank you very much. That's regarding chorea.
Thank you, Prof. Kumar, for the interesting topic of the Korea. Is there any question from the participant about three topics that has delivered from the Prof. Kumar? You can use the raise hand panel, or you can just turn on your mic if you want to ask directly to Prof. Kumar. Okay, Prof. Kumar, before, while we're waiting for the participant to ask, I want to ask a question about the Korea. What we do, the first approach that we have to do if we found acute onset Korea in adult, what we have to do for the first thing that we have to do.
Yeah. So if you have acute onset, that means we're not dealing with HD, right? We wrote HD, so that what doesn't work because that was for family history and slowly progressive. We are dealing with acute onset. That means we are dealing something very treatable, something secondary. And that includes stroke, that includes hyperglycemia, that includes some other metabolic disorder like hypocalcemia, hypercalcemia, hypoparathyroidism. So first thing we have to do, we have to rule out metabolic condition, right? So one simple blood test by evening, you will get by sugar, you will get in few seconds time, the rest of blood test will get by evening. And to treat that, all metabolic condition, when you treat, patient improves, right? But suppose a patient has stroke, they want the stroke improve in 1 day time. Even in metabolic also, sometimes it takes time to improve, right? So we explain to the patient that this chorea is because of this condition. It will take some time to improve. But if it's interfering with your activity, or you see that there's a lot of movement, then you have to start treatment. And best treatment, as we all know, is tetrabenazine. So tetrabenazine is one of the best treatment in the chorea. So that I start in 25 milligram half tablet twice a day for 2-3 days, and gradually build up to 25 milligram maximum 3 times a day. You can go beyond that also, but higher dose of tetrabenazine may cause slowness, Parkinsonism, and depression. So one tablet, 25 milligram of tetrabenazine 2 times or 3 times a day. If your country has due tetrabenazine or valbenazine, that's also okay, but tetrabenazine is.
Mostly patient in Indonesia, we have like insurance from the government called BPJS, and the we don't have like carbonizing or tetrabenazine for in BPJS. So is there any
Oh,
other
okay, good. So you don't have tetrabenazine, right?
yes.
Okay. So in that case, short course of antipsychotics, which is not first generation, because first generation will cause more problem in due course of time. So second or third generation antipsychotic that works. In that case, two medications I will name. If it's there, it's a wonderful medication. One is clozapine, and one is olanzapine. So these two has great antidyskinetic property, to the extent that clozapine is also used in levodopa-induced chorea, levodopa-induced dyskinesia. So acute onset, you have to control that. If you don't have tetrabenazine, then clozapine, if you can use, then wonderful. Or if clozapine again has some monitoring issue, because you have to monitor blood, you are giving clozapine, it can cause myelosuppression, which I can tell you that is overhyped. Myelosuppression happens very rarely, but still you have some problem. Then olanzapine is a good medication, 2.5 milligram twice a day. Start with once a day, twice a day, that will go. Finally, there are some situations where chorea is so bad that patient, they don't have patience, they cannot wait. The best medication is actually Senin, haloperidol. But when you give haldol for a long time, it can cause dystonia itself. So we give for 3 days, 4 days, 7 days, control it, and gradually taper off. So haldol is a good medication for acute control of chorea.
Some of Korea, even it is the secondary Korea, some of Korea usually preserve. They didn't even if we treat the etiology, they still preserve. So what can we do if the Korea is still preserved?
Yeah, so chorea, that's a good question. In fact, hyperglycemia also, we say that chorea improves. That's true. But in some cases, a small number of cases, it persists in low frequency. In case of chorea gravidorum, which we know that after pregnancy, it should improve, but some case doesn't improve. It stays for lifelong, right? In that case, we have to see, are we dealing with only chorea, or are we dealing with chorea with some other abnormalities? Because many times they have some Parkinsonism, some dystonia. But if you're asking question only chorea, I'll give olanzapine. Olanzapine is safe medication for long term. Small dose of olanzapine for long time, or small dose of clozapine if they can afford to go for repeated tests. One more medication has been tried and found effective is amantadine. Amantadine is a good anti-chorea, good anti-dyskinesia property. It's used in levodopa-induced chorea. Because this is effective in levodopa-induced chorea, they have used in other conditions also, and they found effective. So these 2-3 options you have in absence of tetrabenazine.
Okay, it is sharing in Indonesia. Maybe we can use clozapine because it is for the insurance from the government. Clozapine is we can use for a long-term medication, right?
Yeah. Dr. Santosha knows that tetrabenazine is easily available in India, and the cost is say 1/10 of $1 for one tablet. So it's easy for us to use, but I know that's difficult in a lot of countries.
Yes. Yes, it is difficult. Okay, is there any question from the participant? Let me see.
We cannot hear, Sivi. Somebody is trying to ask question, but
Yes.
Excuse me.
You
Yeah, excuse me, Professor and Dr. Elta. Can I ask some questions?
okay? Please. Maybe you can say your name first, then
Sure.
you can.
Okay.
Yes.
Is there any or are there any lifestyle changes that are therapies that non-pharmacological management that can help manage movement disorder? I think it may be not a main therapist for movement disorder, but what can we educate patient to improve their therapies? Thank you, Professor and Dr. Elta.
Thank you. It's a great question. And I would say movement is so wide that answer won't be a common that yes, you would do this, it'll improve. Like for HD behaves differently as compared to Parkinson disease, right? But I would tell more about Parkinson disease because there's some evidence in Parkinson disease that lifestyle modification, some non-pharmacological medication that works. So in that case, I would say that Parkinson disease, first of all, in any movement disorders, I will be against over treating a movement. So you keep on asking the patient that how it's affecting your life, and only then we treat. Number one. Number two, Parkinson's is well known. There's some cellular study to see neuroprotective effect of exercise. So exercise, if the patient comes to you or me, first thing I do that improve your exercise, do exercise regularly, and you find yourself change. Exercise helps in both way, peripheral, that means it supports the muscle, and also central because there's some evidence for that. When you think of your clinic, the patients who are more fit, who do more exercise, they remain well for long time. Those are unfit, they need higher and higher dose of levodopa and they have difficulty. Those who remain fit, they are well managed on DBS. Suppose the time for DBS comes, they are well fit. So to answer your question, one thing I would say that start exercise, there's no way out. What exercise? More of cardiac exercise, means brisk walking. No need to go for huge weight. More of flexibility exercise. In our country, yoga is common, so we say yoga, flexibility exercise, and all the time. So yoga, cardiac exercise, and all the time weight training is a taboo for elderly. People feel that weight training should not be done. But I can tell you that your Parkinson will lose muscle in few years' time. So always have to have little better muscle to start with. So small weight, 1 kg, 2 kg, 5 kg, whatever patient can manage. So weight training should be part of regime. So cardiac exercise, flexibility, as per the local culture, you can use various types. We use yoga quite a lot, and then some weight training. So that's exercise. Apart from that, sleep is very important. So those patients who sleep well, they do well in the daytime. So there's a word known as sleep benefit. When they sleep well in the morning time, they'll find they'll do well. Think of a Parkinson's patient. If you don't let them sleep for few days, daytime motor symptom will be difficult as well as non-motor. Means they will be irritable. They will be more anxious, which is part of Parkinson's disease. So we suggest sleep well. Third, we say that Parkinson's has any patient, they feel I won't take sleeping pill. I'm almost against that because if needed, sleeping pill is important. Sleep is very important, whatever way it is, because many Parkinson's patient has REM sleep behavior disorder. In the night time, they shout, they don't sleep well. The spouse they get hit. Clonazepam small dose, there is no harm in that. So I'm for giving pill if needed for the sleep, right? Clonazepam and melatonin, these are two good medications. Apart from that, non-pharmacological, you're asking about food and some lifestyle changes. So nocturia is important in Parkinson's disease. Nocturia is very common. And when you have nocturia, that means you have to get up in the night more. If you get up in the night, you may fall because you're off. You have taken medicine in the evening time or night time. So to prevent nocturia, we give medications like tolterodine or mirabegron. But we ask the patient to take care of your bladder. Make it clean, number one. Number two, don't take any tea, coffee, or more fluid in the evening time because then you have to get up more in the night time. You will fall more. So these things are there. And food, unfortunately, no food material has proven value. They talk about coconut oil in huge amount, but the data is not convincing. Moreover, coconut oil in huge amount can cause more cardiac problem or vascular problem. But some data is then in favor of antioxidant found in the food, like curcumin, like cinnamon. Cinnamon has some evidence. In animal study, it has evidence. So cinnamon powder, in many clinics, and I also ask them to take cinnamon powder, a little bit of, say, 1 teaspoon every day in various forms, either in tea or coffee or something like that. So these things are important.
Okay. Thank you, Prof. Kumar, and thank you, Dr. Siwi. We have Dr. Santoso here, and maybe I would ask a little, just sharing, a little sharing about the experience, how to assess how the differences to assess patient with movement disorder in India and in Indonesia. Uh, what we have to do to improve how we assess the movement disorder patient. Maybe you can just share us a little your
Uh,
experience.
Okay, thank you. Thank you, Dr. Elta. So actually, I want to ask to Dr. Kumar first. Is it okay?
Yeah.
Yeah. So you are very often to do levodopa challenge for the patient with suspected Parkinson disease. So when we have to stop, I mean, is it just for the physiologic dose of levodopa, or we can continue until we find the optimal dose so, to control the, I mean, the symptoms of Parkinson disease? That's my question
Yeah,
first.
yeah. So that's again a very good question. When we use the word levodopa challenge, the times have changed, and levodopa challenge has limited value nowadays, right? Challenge, I'm talking about acute challenge. So acute challenge we do only in those cases of Parkinson disease where we are thinking of deep DBS surgery. When I think of DBS surgery, then one tenet, one indication of DBS surgery is that patient should respond to levodopa. If no response, then they won't respond to DBS surgery also. Patient may tell you that I have responded or not. I want to see in front of my eyes. So what we do, we call the patient off phase. We give double dose of levodopa what they're taking in off phase, and we see on, and we see UPDRS on and off phase. If difference of 30%, that means they have responded, and that is proper levodopa challenge. So that's one. Second scenario, which is very important, that many patient comes to us having Parkinson's-like feature. They may have MSA, multisystem atrophy. They may have PSP. They may have vascular Parkinsonism. In that case, what to do? They may have PD also. In that case, again, we give levodopa because levodopa is not harmful. It can work in everywhere, more in Parkinson disease. So in that case, we don't do acute challenge because in many studies, and we also have seen that it might take few weeks time for levodopa to work properly. That's why we start levodopa. We call back again in few weeks' time to see how the patient has responded. So to answer your question, Dr. Santosho, we give levodopa in case of DBS indication, acute. In other cases, we give slowly and bring back in 3 to 4 months' time. The question is that how long, how much dose? So at what dose we should feel that, okay, it's not working. We should stop it or it's not working. So at least 600 to 800 milligram only then, because many patient takes 400 milligram to cross the blood-brain barrier. So below 400, don't think about that. If you take 2 tablets and feel that the patient has not worked, don't think that. So build up to 1 tablet 4 times a day, bring back again. Then patient is not responding, go to 1.5 tablet 4 times a day. So 600, 700, 800. If patient is not responding, then I'm despondent. Then I'm disappointed that it's not working. So 6 to 800, at least 3 months time. Only then we see that yes, the patient is not responding.
Yes, because as I hear that the trick for the PD patient is also you said that if a young person, I mean young onset, so don't think first for the levodopa, but you also very often to use for the diagnosis, I think. Okay. And regarding for the regarding for the request for Dr. Elta, well, based on my experience, this is actually just observation. So correct me if I'm wrong. For the management of movement disorders, comparing with the in India and also in Indonesia. So first of all, I would say that we have similarity for the system referral. So in India also from general started from the general neurologist and then to the movement disorders fellow and then I mean super specialty, something like that. It is similar like in our country, but I think we have to improve our communication between general neurologists to the and movement disorder specialists in in this country. That's the first. And the second is for the drug availability. I think Dr. Elta said that we have government insurance, which is maybe 19% of our patients is covered by that insurance. And the drug availability for this insurance is have some kind of restriction and also some kind maybe with the lack of availability for some drugs. So we have to choose the alternative drugs for this, and then we have to fight. I mean, we have to always give a suggestion to the person in charge for this insurance. I think that's it. And again, for the assessment, I think we have already discussed also in India, Dr. Hrishikesh Kumar, that we have a lack for the resources. For example, like a genetic testing for the sportive, like imaging, something like that. Then what should this is also a question for the for this forum. So what should we do if, for example, okay, this patient is suspected with genetic disorders, and then we have to, and then we can continue. We cannot. I mean, we cannot continue for the further investigation. So this is quite like I mean, for the movement disorder specialist, this is like a disappointment for us. So we cannot follow up the exact diagnosis for this. So I think, and then I think from Indonesian Association of Neurology, we have started for the register for the rare disorder, right? So we can start from that. We can collect the case and then register for the symptomatology, and also we can, I mean, then we can develop the good system for that. I think that's for my sharing of my experience. Thank you.
Dr. Eta, can I respond to that?
Yeah.
Yeah. So thank you, Dr. Santosha. It's a wonderful insight. I would say two things. First of all, medications is not in our hand, your hand. It's government to work on that. But I found that some medications are very important and they should allow. They should do it cheap. And that includes levodopa, of course. That includes this tetrabenazine is very, very important because this helps. So somehow the advocacy should be there to include that in the Mediclaim or include that in the insurance. So that's one. There are ways to, like in my country, some medications were not there, say 15 years back. There are ways to get it from the foreign country. So, and legal ways, not illegal ways. So so you have to explore that if any supplier can get it from countries like India, which will be very cheap, and whether they can give it or not. Bangladesh is our neighbor, and they get a lot of medications from India. Now they have good government and they're giving a lot of medications, but till date, many medications that goes to Bangladesh from India through their legal supplier. Okay, so I don't know how to do that. So, but you have to see, like in some patient, my patient, they are very fond of Cinemet. Cinemet is levodopa, but foreign make, and we have Syndopa. So we have drug stores. They deal with the foreign medication. Okay, so that you can think of one. Second thing regarding genetics, when I studied, say 20 years back, neurology, there was no genetics, right? And still, it was beautiful to study because I'm telling you, the genetics is very good. It gives you answer. At the same time, bad because it stops your thought process. Once you have something Korea, you send genetics and you get some answer. And now you're working on the paper, what it came. You're not working on patient. So I would say we should not be sad that genetics is not there. It will come in due course of time. Of course, it will come in due course of time. But I think that this is the time for all the residents, all the students, and all of us that if patient is there with a phenomenon, we should have differential diagnosis. All that I'm different. So when the patient, there is no need to go for final diagnosis. I feel that this is first differential diagnosis. So this should be there. In fact, that will help you to hone the skill. Finally, there's no harm in having sharing the case with those people who see them a lot and who have genetic say report. You don't send blood. Still, when we see the pattern, okay, this pattern has chorea with dystonia, early onset, autosomal dominant. I can think of ADCY5, think of giving caffeine. So what Dr. Eltra has just suggested, that interaction is very important regarding video interaction, and movement disorder is beautifully in that, because when we interact with the patient, at least we can zero in that these 3-4 things are there, and we can treat accordingly. Finally, again, we should not be sad about lack of genetics, because treatable conditions, they don't need genetics. Generally, treatable condition, you'll know by blood test and you will know by MRI, right? You will know by CSF, autoimmune profile. So whatever treatable condition, genetics is not needed, right? So at least don't miss treatable condition, and rest we can wait for genetics.
And still the genetic examination is maybe is very difficult to to do in our country with government insurance.
Yeah,
But maybe that's our homework to propose for the government to
yeah.
include it some medication or maybe some examination that we need to assess the movement disorder patients. That's our homework, Prof. Okay, maybe the time is up. If there's no other questions, maybe I will make a little conclusion about this lecture. The first one is it is important to differentiate the phenomenology of the movement disorder, whether it is the hyperkinetic or is hypokinetic, to assess the movement disorder patient for and it is important that we have to uh, look at or define what the gate for to define what is the phenomenology or what is the uh, movement disorder that involve for the patient. And the last is we have to see about the chorea. The first one that we have to see whether it's Huntington or Sydenham, whether in adult or in a child, and if uh, whether it's not the two of the Huntington or Sydenham chorea, we have to think about other approach of the etiology of the chorea. Maybe that's the a little conclusion that I can make for today's lecture. And I would like once again thank you for Prof. Kumar for the very interesting lecture. Hopefully we can stay in touch and maybe we can discuss further for another case or maybe another topic of the movement disorder. And thank you, Dr. Santosa, and thank you for Dr. Banon and any other another participant that have joined this lecture. So I will give the time back to the MC. Please, Dr. Siwi.
Well, okay, as we draw the curtains on this enlightening guest lecture, I extend my gratitude to each participant and speaker and supporter who contributed to the success of our endeavor. The wealth of knowledge shared and depth of insight explored have undoubtedly left an indelible mark on our collective understanding of movement disorder. As we depart from this virtual gathering, may we carry forth the spirit of curiosity, innovation, and collaboration that has defined our time together. To Professor Kumar, as a token of gratitude from us, there will be a certificate in physical form that will be delivered by Dr. Santoso. Until we meet again, may you remain inspired in your pursuit and knowledge and growth. Thank you once again, Professor, Doctor, and all participants. Bye-bye. Thank you.
Thank you, Dr. Kumar. Thank you, Dr. Santoso, Dr. Banon. Thank you all.
Thank you very much. Thank you.
So what I was saying, Dr. Santosh, is that anybody needs presentation, I'm happy to share that. And I did not touch upon few conditions because of paucity of time. We can do later, like tremor or dystonia of myoclonus.
Yes, sir. Please. My pleasure to have your presentation. Thank you.
I share it. Thank you. It was wonderful interacting with everybody.
Yes.
Maybe we'll see sometime in real world rather than virtual world. All the best.
Yeah, all the best, sir. Thank you.
And convey my regards to everybody there, your
Yeah.
HOD and everybody there. Thank you.
Yes, sir. Thank you.